Hello, my name is Raphael Mechoulam. I'm a professor at the Hebrew University in Jerusalem. I'm a chemist working on the chemistry of natural products, and cannabis and cannabinoids has been one of the topics my group has been working on for many years. And I sincerely hope that cannabinoids will contribute to our understanding of human physiology, animal physiology, and I expect that new drugs will, based on the cannabinoids, whether they come from the plant or whether they come from the compounds that we make, will become drugs in the near future.
Where do they go, the smoke rings I blow each night? Oh.
Hello, listener, and welcome back to the Professionally Cannabis Podcast. Last week we had a special episode with a British MP, and I am very, very happy to say that this week we have perhaps the most special guest that we could have ever had on the podcast. Oscar, could you fill in the blanks?
Yes. And I don't think you're exaggerating to say this is the most special guest we could have, because Dr. Raphael Mechoulam, our guest, was the first person to actually take the cannabis plant and say, let's look down at the chemical components of what's happening here and actually really understand why it's working. Cannabis, of course, was used for thousands of years, but never explored or the chemical structure elucidated before Dr. Raphael Mechoulam's work. And then, 30 years later, he then went on to find the endocannabinoids produced in the human body, thereby bringing the human race up to speed on its own endocannabinoid system, and a very important physiological homeostatic balancing system that he explains in this episode far better than I ever could, and its discovery, and has led to this whole new branch of medicine, this exciting industry. Everyone that we talk to on this podcast, they're only here because of Dr. Mechoulam's work. Yes, I mean, as you can tell by this sort of breathy intro, I am very excited about this one, Jonathan. Maybe you can talk about it more somberly, because I can't. It's incredible. What a scalp for us. Well, not a scalp. We didn't take a scalp, but you know what I mean.
That would have been a bad way to finish the interview, but no, it was a real honor, certainly for myself, and I'm sure for Oscar as well, for us to even have a conversation with Dr. Mechoulam. How did you find being in his company?
Honestly, I went into it prepared to be a bit of a fanboy. I knew I was excited to meet him, but then when we were going through the conversation, the stories he brought out, his cogency in his second or third language at 90 years old was just unbelievable. The mind on this guy is incredible, and it comes through in every aspect of our conversation with him. I think our listeners are really going to be delighted by this one.
Well, it's time to bring you the Professionally Cannabis Podcast episode with Dr. Raphael Mechoulam. Listeners, enjoy.
Where do they go, the smoke?
When Oscar and I started this podcast early last year, I did not think that I'd have the opportunity to say this. It is an honour to welcome to the pod the Godfather of Cannabis, a man that needs no introduction, but we'll give him one anyway, Professor Raphael Mechoulam of the Hebrew University of Jerusalem in Israel. Raphael, welcome to the Professionally Cannabis Podcast.
It's a pleasure.
Raphael, I'm starstruck to have you. So typically when we open our interviews, we ask what led you to the plant, which I will ask you here, but I wonder if it's too thin a question for you. But Dr. Mechoulam, please, what led you to the plant?
Well, I'm a natural products chemist. Namely, I work on the chemistry of plants or a chemistry of other natural products. I worked on quite a few plant constituents and animal constituents. I was surprised to see, by reading the old literature, that cannabis was not well known chemically. Now, that was strange, because morphine from opium was pretty well known, and cocaine from coca leaves was pretty well known, and there was a lot of pharmacological and clinical work on these two compounds, and more on morphine and cocaine. But cannabis had been left behind. And you see, nowadays, one cannot go ahead with pharmacology or clinical experimentation and so on without having a good chemical basis. And as I said, I was surprised that this was not so. Actually, two outstanding chemists, one in the UK, who later got the Nobel Prize for something else entirely, Alex Todd, and another in the US, had worked on cannabis in the 30s, early 40s. But again, surprisingly, the active compound had never been isolated in pure form. It was not known whether there is one compound, whether there are many other compounds, whether additional components, constituents have an effect, and so on. And so I decided to try and renew interest in cannabis. At that time, there was essentially no interest whatsoever. As a matter of fact, I asked some of my colleagues, NIH, National Institute of Health in the US, whether they would be interested in supporting research on cannabinoids or cannabis. And they said, well, no, we're not interested. It is something that's being used in Mexico and probably a few other places, not in the US. When you have something more relevant to the US, why don't you contact us then? Well, at that time, what I said at least, very few people were using cannabis in the US. They said, well, a few black musicians use it, but no, it's unknown. Then a year later, actually, a person from NIH flew over and said, yes, all of a sudden they are interested. It turned out that the son of somebody important, maybe a senator, had been caught smoking pot. And the senator, whoever the important person was, asked NIH, what do you know about cannabis? Is it going to destroy my son's brain? And they didn't know anything about it because the NIH had not supported any research on cannabis at that time. Now they support it heavily. And they recalled it a young fellow, and I was a young fellow, that was in the 1960s, had asked them for support. So he flew over and said, yes, we're willing to support your work. And at that time, we had already isolated the active compound. We found that there is only one active, marijuana-like active, although quite a few others are active in other ways, but there was only one constituent. We had isolated it in pure form, and we had just elucidated its structure. So he took the world supply of THC back to the States. I'm under the impression that he smuggled it. I doubt whether he had the okay to take it with him, but I don't know. Anyway, he's not around anymore. As I said, that was the early 60s. And quite a bit of the early work on cannabis and THC was done with material that they got from me. And they were quite happy. And the NIH, the US NIH, supported my work for nearly 45 years. Well, going back to the research, we got cannabis, hashish actually, from the police. I asked the administrator of my institute whether he knows anybody in the police to give me cannabis for research. And he called a friend of his, and a friend of his asked, I could hear him on the phone, is he reliable? And the fellow, the administrative person who was in charge said, of course, totally reliable. He barely knew me, actually. And so I went to the police, had a cup of coffee with a person there, number 2 or 3 in the police. I got 5 kilos of hashish, took it with me on a bus. I didn't have a car at that time. And people on the bus were kind of, said, there's a strange smell around here. And nobody knew what the smell was. Anyway, I took it back to the lab, and together with colleagues of mine, we started looking at cannabis, we first re-isolated cannabidiol. This is a compound that had been isolated previously in the US and in the UK, but the structure was unknown, and there had been no work on cannabidiol over, 20 years, which is a little bit strange if you look at what's happening with cannabidiol today. But anyway, we re-isolated cannabidiol, we elucidated its structure, and then we went ahead looking for other compounds. We isolated compound, which we called cannabigerol. There are chemical reasons why we called it that. And later we isolated THC, tetrahydrocannabinol, and again, elucidated its structure. And later we synthesized it. And together with some other of my friends, collaborated on its pharmacology. We took, my colleagues at an institute, biological institute, not far away from where I worked at the Weizmann Institute at that time. He took THC and he compared THC with THC plus 3 or 4 or 5 other constituents. And he also looked at the other constituents, the activity of the other constituents. And he found that THC was the only one that was psychoactive in the marijuana type activity. And we published that. And surprisingly, at that time, the Americans discovered that, well, cannabis was relevant to what was going on in the States. A few people were using it. It was the 60s, the mid-60s, and all of a sudden millions were using it, and they really wanted to know a bit about it. So we went ahead. We had the money to do that, and we worked on isolation of quite a few other constituents of cannabis. We worked on the pharmacology, worked in collaboration with others, and the physiology. We actually, again, with collaborators, and this time in South America, we worked on clinical trials. We isolated a huge amount of cannabidiol, about half a kilo, 450 grams of cannabidiol, again from hashish from the police. And it's a crystalline compound. And we sent it to South America, and they tested it for epilepsy. And yes, it was an excellent compound for
How did you know to test it for epilepsy that early? Because currently people know about Epidiolex and Charlotte Figgis in 2013, but you were doing this in the 80s, were you not?
Yeah, well, yes. We based our work on previous publications. Cannabis, crude cannabis, had been used in epilepsy for centuries. Not a lot, but it had been used. As a matter of fact, a colleague of mine in Princeton found some manuscripts, Arab manuscripts from the 15th century, that an important person, the son of a vizier or whatever he was, had epilepsy, and they gave him cannabis, and he didn't have any attacks anymore, but he had to use cannabis ever since. So that was the 15th century, and there are quite a few others that were, some of it had been published. And my friends in South America, and I still collaborate with them. My friends in South America tried it, of course, first in mice and various types of preclinical investigations. And when that was okay, and the toxicity, the lack of toxicity was seen, they could give it to patients. And we did a clinical investigation on about 15 patients. Half of them got pure cannabidiol, quite a bit actually, between 200 and 300 milligrams a day. And the other half got the same solvent, but no CBD. And of course, those that didn't get anything continued to have attacks. And those that got the cannabidiol, 3 or 4 of them had essentially no attacks. And these were really very sick people. 3 or 4 had much less, and only 1 was not affected. So we published that. That was 1980, quite a few years after we had started work on cannabis. And I thought, well, there is a need for a new compound for epilepsy. Maybe somebody, maybe a company can do a major investigation, several hundred patients. Of course, as an academic lab, we couldn't do that. The 15 patients that my friends did was just as much as they could do. And nothing happened. Nothing happened for 30 years. And then going ahead 30 years, parents in the US, maybe somebody had read my paper, or maybe just happened some other way, so that cannabis that contains a lot of cannabidiol helps their children, that nothing else was helping them. So quite a few of them went to one of the states that had free cannabis, and they found that, yes, free cannabis was helpful as long as it contained a lot of cannabidiol. So this went ahead, and quite a few people started using it in the States. And in the States, public things that happen around do influence the government. And NIH or whoever has to approve clinical trials, not NIH, it's some
FDA?
Other FDA, yes.
Mm-hmm.
The FDA approved a clinical trial, which they hadn't approved for anything stemming from cannabis previously. And a large clinical trial was done. It was completed a year ago. It was actually done by a British company, JW.
Mm-hmm.
And yes, it worked very well. And they got an okay. And today, cannabidiol is an approved drug under a different name, of course. And quite a few people are using it. And it's very helpful. Now, why did we have to wait for 30 years? I mean, cannabidiol could have helped, well, maybe thousands of children with their epilepsy. Just nobody went ahead. Nobody was interested. I gave lectures on the CBD and epilepsy and so on, but we couldn't push it ahead, and that was it. In the meantime, we went ahead, and I'm going back to the 70s and so on, with the metabolism, with all kinds of other investigations. And we started publishing on the chemistry, pharmacology, physiology, and quite a lot was known. Many other groups joined us, and including a few in the US, in the UK. A good friend of mine, Pertwee, he was at Oxford at that time, mm-hmm. and then he moved to Scotland, and we still do joint work from time to time, and there were a few others. And quite a lot was known about cannabis by the 1980s. One thing was unknown. How does cannabis work? What's the mechanism? And there was quite a bit of a problem. People were suggesting all kinds of things. We published a paper showing that from a chemical point of view, there may be something called a receptor, maybe, or THC or CBD act on something else, but we couldn't go ahead until a group in the US, Alan Howlett, again, a good friend of mine now, she found, and that was in the early 80s or mid-80s, that there is a receptor. There is something in the body that THC binds to, and then we see all the effects that we know of THC. So as many other compounds that act on receptors, here THC was found to have a receptor of its own, particularly in the brain. Now, we don't have receptors because there are plants out there. We have receptors because we produce something, compounds, usually, that affect this receptor. So we went ahead looking for these theoretical compounds that may be present in the brain. And as a matter of fact, I asked a PhD student, Raphael Mechoulam, whether he wants to come over and do a postdoc with me in Jerusalem. I had moved in the meantime from the Weizmann Institute to the Hebrew University in Jerusalem, and I had a lab that was working in part, at least, on cannabis. And we started looking for that compound, which is a pretty difficult thing to do. I wouldn't go into all the things we had to do. We had to radio-label a compound, and like THC, but much more potent. We had to bind into the receptor that was previously seen. And then we had to try brain extracts that bind to the receptor. We had a receptor with that radioactive compound bound to it. When we take extracts from the brain that bind to the receptor, they will go to the receptor and kick out the radioactive compound. And then we can measure the radioactive compound, which has been kicked out from its binding to the receptor. Anyway, this is technology. And after quite a bit of work, it was possible to isolate the compound. And we isolated that compound in the early 90s. It's quite a few years after we started work on cannabis. And in 1992, we published a paper saying, yes, we have a compound that we isolated from mouse brain, and it is a compound that binds to that specific receptor, and it does all kinds of other things that THC does. And actually, my good friend Roger Pertwee, we sent him some material, and he said, yes, it acts on one of the very specific reactions of THC. So that was it. We call the compound anandamide. It's based on ananda, which in Sanskrit is supreme joy. And the anandamide has been in the literature now. There are about 6,000 papers on anandamide because it's a new biological system. People didn't know that there is a system which we today call the endocannabinoid system, which is based on anandamide, which is based on the receptor. There are 2 receptors today, not only one. And so there is a lot of interest, for it was found that this new biological system is involved in a huge, huge number of disease states. And it is involved in a huge number of regular biological reactions. And so, of course, there is a lot of work by scientists in the US, in Europe, in Japan, working on anandamide. Later, we found a second compound, which is known as 2-AG. And these 2 compounds have been found to be of great importance. And there we stand today with a lot of work. If you wish, I can tell you a little bit of the things we're working on at present. At present means the last 10 years.
As far as I understand, despite being something that's produced in humans and animals, there has been little to no administration of anandamide to humans. Why is that?
Well, I think that you exaggerate. You say there has very little. There has been essentially none. N-O-N-E. None. And the reason for that is very strange. You see, if you compare that with insulin, which was discovered 100 years ago in Canada. Insulin was discovered and found that it has to do with sugar metabolism. And within 6 months or a year, it was given to humans and it became a drug within a year or 2. Not a bad drug at all. It's still being used. By comparison, we discovered anandamide in 1992, and except for 1 or 2 very, very minor examinations in humans, it has not been administered. You see, today, in order to administer a new compound to a human being, you need a lot of work, which costs a lot of money. Companies do that. But here you have a natural product. We didn't have a patent on that. We thought that maybe it will be used widely without a patent. So no company has volunteered to do that. Governments speak about research, but they don't do much about it. So anandamide, although it is a natural product, it is known not to be toxic. Its effects are known, but it has not been investigated in humans, although to the best of my understanding, it could be an excellent drug. But again, it has not been investigated.
With regard to anandamide, and of course other compounds within cannabis, what can be said is that there's been a profound lack of clinical trials and clinical data. If governments and pharma companies aren't going to be funding a plethora of these clinical studies, Where do you think that funding can and should come from? And what relationships have you experienced between the business side of the cannabis industry and the research side of the cannabis industry?
Well, THC and cannabidiol separately have been found to have medical importance. We have seen, and many others have seen, the THC given at low doses can lower anxiety and works pretty well in post-trauma, PTSD. Cannabidiol was, for example, investigated in Germany at pretty high doses, about 800 milligrams a day, given to schizophrenic patients, cannabidiol. And it worked very well indeed. And the group that did that work, an excellent group, a very reputable group, published that. And that was 6 or 7 years ago. And we need compounds, new drugs for schizophrenia. And yet, there we are. It has not been approved as a drug, and it cannot be administered as a drug. So the problems seem to be mostly legal and have also to do with patents and so on. But the fact is that cannabidiol has been approved for epilepsy. And as I said before, it could have been approved as a drug against epilepsy decades ago. Mm-hmm. And nothing else. Why not? There are a lot of other diseases or disease states that cannabinoids could have been used. And anxiety, for example, quite a few people have anxiety, and one has to do good clinical trials in anxiety, both with THC and cannabidiol, and find out how to do these things. Now, these clinical trials are not simple. For THC at low doses has anti-anxiety effects, for example, but at high doses, it can cause the reverse. And obviously, we cannot give a person with anxiety high doses of THC because it can cause undesirable effects. But one has to find out how to do these things. Now, let me go a little bit ahead. You see, anandamide is a compound that the body prepares from a fatty acid and an amino acid. But the body has a lot of fatty acids and it has a lot of amino acids. And our body, if possible, is lazy. It knows how to make anandamide and it has the machinery for that. So it uses this particular machinery, if you wish, to make a lot of other compounds. And these compounds, many of them are very active. We have about 100 of them in the body. And so we were looking, and we have been looking over the last 10 years on the activity of these compounds. And we found that one of them helps with brain trauma. A good friend of mine, she's a specialist in brain trauma, and found that one of these compounds, an anandamide-like compound, lowers the damage in the brain from brain trauma. And we published that. With another colleague of mine, we found that a related compound, again, fatty acid bound to an amino acid, an anandamide-like compound that our brain makes and our bones make, works against osteoporosis. And it is very active against osteoporosis. So we published that, and practically nobody uses that, although it can be developed to help osteoporosis, bone disease it's prevalent. Over the last 3 or 4 years, we did something else. We looked for compounds that act on addiction. And you see, addiction is a very complicated situation. For many years, people thought that addiction has nothing to do with biochemistry and so on. It's something else, psychological completely. Well, over the last 10, 15 years, the people have found out that it's a disease like any other disease. Of course, there are several types of addictions and so on. So if there is that type of disease, maybe our body tries to lower the damage. But most of the research done on addiction has been on the addicted people, not on those that are not addicted. People that smoke nicotine, smoke cigarettes, many of them get addicted, but some of them don't. Why don't they get addicted? Maybe the body makes something that prevents the addiction. So with colleagues, and here I have a story that might interest you. We sat 4 groups, friends, drank a lot of coffee together, a group in the US, a group in Canada, a group in Italy, and my group. I mean, we sat 4 of us, very good, very close friends. We said, let's look and try to find how the body tries to block addictions. And we started with nicotine in mice, of course, and each one of us did something part of that. And we found that a particular place in the body makes a compound, an anandamide-like compound, that lowers or even blocks nicotine addiction. And this was done by our 4 groups. The publication says a group in Israel, a group in Canada, which did a lot of work, a group in the US, and a group in Italy. Together, we found that that particular compound blocks nicotine addiction. And even more so, this particular compound blocks withdrawal effects, not only of nicotine, but also of opioids, also of heroin in mice. Of course, we cannot go into humans, and nobody has volunteered to do that work, but it blocks withdrawal effects in mice, probably in humans. And the group in Canada is going ahead with that kind of work, and it has found that, yes, indeed, this particular compound is very good in blocking addiction. And it's an anandamide-like compound, so it's a, if you wish, endocannabinoid, part of the endocannabinoid system. And we have even made a compound which is even better than the compound that the brain makes. But again, nobody's going ahead investigating in humans. And there are quite a few addicted people all over the world, in the US, in Canada. At this particular moment, I believe that one should look at both the anti-addiction effect and nicotine and anti-withdrawal effects in both nicotine and heroin. A lot of people that want to get out of the addiction they have to stop it. They're very much afraid of the withdrawal symptoms. Mm-hmm. And here we have a compound that blocks the withdrawal symptoms. It is not being used. Your guess why is good as mine.
We've talked a lot about anandamide-like compounds or cannabinoids that are produced in the body. And my question to you is, do you believe there is more promise there for future medical products than there are in replicating or isolating plant-based cannabinoids within the cannabis plant?
The answer is, we don't know. You see, many of the drugs that we have today, probably 50% of the drugs that we have today are based on natural products, plants, fungi, whatever, that have been modified. After all, the plant doesn't make it for us. It makes it for whatever it needs it for. But we are a little bit different than plants. So the compound that the plant makes very frequently has been modified to a certain extent, and the companies also know that if they modify, they have a patent. They modify it, and then they have pretty good drugs. Penicillin, you cannot buy penicillin in the pharmacy. You can buy a derivative of penicillin. Mm-hmm. The same is true is cortisone, a hormone that we produce, very important. And of course, you can buy cortisone-like compounds and they're being sold for billions and billions of dollars. So here again, maybe cannabidiol in the future will not be used as cannabidiol, but as a derivative of cannabidiol. Cannabidiol, as I mentioned before, is active in schizophrenia at 800 milligrams or 1,000 to 1 gram a day, which is quite a bit. But we and others have made cannabidiol-like compounds that are just as active or maybe even more active, and the doses that are used are much lower. So here we have compounds that can be used from the plant. They're very useful for certain things. For other things, we can use the compounds that our body makes, like the compound against osteoporosis. These are two different things, and osteoporosis is a difficult and unpleasant disease, and if we can use a new drug, why not? So there is a lot to be learned, a lot to be, after clinical trials, a lot of compounds to be used. So one shouldn't say one against the other. On the contrary, both types of compounds are very important. And I'm sorry that the big firms are not developing them.
And do you see, like the epilepsy, which was hinted at in century-old manuscripts, do you see other cannabinoid-based therapies that have been hinted in folk medicine or traditional medicine that are not being investigated properly now? I mean, we've talked of huge gaps already in where we could be using cannabinoids, but are there any further ones from ancient texts?
Well, yes. I mean, quite a lot of cannabis has been used for a lot of things. Queen Victoria, the British Queen Victoria, had strong headaches, and her physician used to import cannabis from India. Apparently, European cannabis was not good, and he gave it to Queen Victoria for her strong headaches. And there are quite a few others. It is not very useful for acute pain, but it is pretty good for long-term pain, particularly cannabidiol. So there is a long list of diseases that are affected by cannabidiol, pure cannabidiol, not necessarily a cannabis mixture, but they have not been thoroughly investigated. And that's a pity, because we need new drugs all the time. Hopefully, this is changing, but I would have preferred to see a much more rapid change, but there we are.
Now, one of the things we haven't touched upon so much yet is focused around the entourage effect. How do you think future pharma product medicines can coexist with trying to bring about benefits brought around by the entourage effect? We see a lot of pharma medicines looking at isolated compounds, which can obviously be more stable and consistent, whereas a lot of the, and as a pioneer of this research, you know it a lot better than me, but a lot of the benefits that come from the entourage effects are coming by combining cannabinoids. What are your thoughts around this?
Well, we described and gave the name, which was actually in French. We gave the name entourage, the entourage effect, because we found that plant cannabinoids and also the anandamide-like compounds and so on affect differently, sometimes much better when they're in an extract of cannabis rather than as the pure compounds. Mm-hmm. And today we know, in many cases, we know the reason for that. With the endogenous compounds, we know that these additional compounds that are found in the plant can prevent the breakdown of the active compounds. The active compounds in the body are made by the body when needed. They act and they're immediately broken down. There are enzymes that break down these compounds. Now, if you have these entourage compounds, some of them, and this is one of the things they do, some of them block the enzymes and the compound and stay in the body for a relatively longer time. Unfortunately, although again, we published an entourage paper and gave the name, 25 years ago, there has been very little work on entourage. People use the term, people say, well, the extract is better than the pure compound, but there have been very few investigations. So we don't know whether this is the only mechanism, the one I told you before, this is the only mechanism or there are other things. But here we definitely see in many cases, not in all cases, that the total extract may be better than the pure compound. But again, in modern medicine, one has to know exactly what is being administered. And if you say total extract, it's not something well defined. What is the total extract? The total extract of one plant can be completely different than the total extract of another plant. Do we have 1 or 2 or 3 compounds that are active? All this has to be known, and we don't. So most of the research, a little bit of research that has been done in human patients has been done with the pure compounds because work with a mixture cannot be repeated exactly. One says, I did an extract. What does the extract contain? So it's okay, one can publish that, but one cannot go ahead. If one takes something well-defined, whether it's a pure compound, and in most cases it's the pure compound, whether it's a pure compound or a mixture, then it's better known. But sometimes mixtures are used. For example, the British company is selling a mixture. It's not an entourage effect. It's a mixture of THC and CBD. They call it Sativex, and it is being sold in quite a few countries for some neurological diseases and so on. So we can go ahead with entourage, but we have to know more. And again, as with many things in cannabinoids, we don't know enough.
I think even over the course of this short conversation, it's come again and again that research has been delayed, products don't come out off the back of promising research, etc. And I suddenly have my own opinion on this, but I wanted to ask you, do you believe that there has been a political chilling effect on cannabis research due to its association with, let's call it the 60s, the perhaps a freedom or lefty movement, in the words of Nixon? Do you think that impact's been very real, slowing down the scientific work? And maybe it's different in Israel.
Well, the answer is yes. You see, working with compounds, giving compounds to human beings is very difficult, very expensive, not a simple thing to do. And this is with compounds that are not covered by laws that are associated with cannabis or with opiates and so on. So it is extremely difficult to do research, particularly in humans. In cannabis, it was almost impossible to do that in the States 20, 25 years ago. You see, you cannot have an academic lab working on natural cannabinoids or THC with students coming in, coming out, and you cannot have somebody standing in the door and looking at what you're doing and whether it can or cannot be done. So it's pretty complicated. And getting the okay from various agencies, not simple. So work to a certain extent is constrained. It was not blocked, but it was difficult. And many groups, academic groups, said, well, I have so many other things to do. Why should I go ahead with all the bureaucracy needed? But some groups continued to work on that. And yes, we have advanced quite a bit, particularly with the endogenous compounds. Our anandamide paper has been cited thousands of times. And this is because the anandamide compounds are not covered with by any law. They're okay. Very difficult to work with THC, both in the US and in other countries. I am not very well aware of what the laws are in the UK or in many of the European countries, but there has been work and things are getting better. And I understand that in most countries, if one really wants to do work with cannabinoids, it can be done. I hope that more clinical work will be done, particularly in the US, with the plant cannabinoids in diseases. How come that the only major clinical trial published has been done with CBD, which is not toxic and so on, in epilepsy alone? There are quite a lot of clinical trials that have been announced. Well, in order to do a clinical trial, one has to announce it, and it appears in a list. And quite a few have been announced, but we haven't seen the publications yet. I hope that we shall see them within the next few years. And maybe, just maybe, cannabinoids will be eventually introduced for many, many other diseases. Anxiety is the simplest thing. Well, anxiety is not the simple thing, but it is relatively easy to do, relatively.
One thing I want to ask, for a man who's affected so much change in what I believe is going to be a very broad area of medicine, the discovery of a whole new physiological system, where do you find the most pride in your legacy? Is it, I don't know, for the children's lives who've been helped by this? Is it for taking a firm stance and saying, no, science should prevail over politicians locking down or showing no interest in topics? Or is it the things to come?
Difficult to say. Obviously, glad that we discovered we were able to identify Delta 90, its E-proof structure. It was way back in the 60s. I'm very proud that in the 90s, quite a few years later, we were able to identify anandamide and 2-AG, which are very central in human physiology, and I hope that they will advance their new drugs and so on. And I'm really happy to see what's going on today with all the anandamide-like compounds. The one that I was describing that works in nicotine addiction and withdrawal effects and bones and lowering brain damage. So there are three different things that are associated, but I'm happy with all three of them. Whether I'll be able to do a lot more, well, I hope I will do a little bit. After all, at the age of 90, it's not so simple to plan for the next 10 years.
Well, we certainly look forward to seeing your research in the years to come. Raphael Mechoulam, thank you so much for joining us on the Professionally Cannabis Podcast.
Well, in that case, it was a pleasure talking to you, and all the best. Bye-bye.
Where do they go? The smoke rings I blow each night.
Well, listeners, I hope you enjoyed that, well, half as much as myself and Jonathan did, because that was really an incredible experience for us. And I apologize for my fast pace of speaking. We've edited it out, but Dr. Mechoulam did ask me to speak at a more comprehensible pace as I got more excited and went on and on. But never mind, if you enjoyed that in any sense, please do the usual favor of subscribing and commenting and sharing the podcast with any other party you think might be interested. And get in touch if there's any more legends you'd like to see on the podcast. I kind of feel like we've had the most legendary person we could have now, but perhaps our listeners think there is someone else whose voice they'd like to hear. Until next time, take care.
Hello, please take me above, take me with you.